Hello anatomy friends, this is Dr. Alsup, and we are about to begin our last video set for this musculoskeletal portion of the course. So we're going to finish our discussion regarding structures of the pelvis as well as the lower limb. So we have much to get through in this particular video because we're going to focus on the bones as well as the joints of the pelvis. And as you can see here, we have a fairly robust set of learning objectives. So please make sure that after you view these videos, you come back and try to answer these in your own words. All right, excellent. So when we use the term pelvic girdle, it's similar to what we had with the pectoral girdle. So this is the means by which the axial skeleton is meeting with the appendicular skeleton. And specifically what we have here are the two coxal bones. Sometimes you hear these referred to as the hip bones. You can see they're quite irregularly shaped. And then you have a connection actually with the vertebral column. Recall that the sacrum is going to be those fused sacral vertebrae, and you can even see a bit of the coccyx here. And what the pelvic girdle does is a lot. It's a little bit more complex. Where we have a bit more mobility when we're talking about the pectoral girdle, the pelvic girdle is more going to play a role in terms of weight bearing. Specifically, you have this here in terms of the function bearing and transferring weight of both the upper body as well as the rest of the axial skeleton to that lower appendicular skeleton. So it needs to be more stable than what we had with the pectoral girdle. As you might imagine, this is also going to be an area of quite a few muscle attachment sites. It is going to protect both pelvic viscera, but also abdominal viscera, specifically the lower or more inferior portions of the abdominal viscera, the GI tract, that is going to be protected by the more superior portions of the pelvic girdle. And then particularly in the more anterior portions, but also the inferior portions, the the pelvic girdle will serve as an attachment point for erectile bodies of the external genitalia. And you'll learn more about what those erectile bodies are going to be associated with when we get into the reproductive sequence of the course. All right, so let's get some of the major categories before we break down the different bones in a bit more detail. One of the major important components of the pelvic girdle is this area referred to as the pelvic brim, because it helps divide this area into different regions. And the pelvic brim is basically just this bony edge. It's going to surround and define what's referred to as the pelvic inlet. So often you hear these two terms used synonymously. Or you may hear the pelvic inlet referred to as the superior pelvic aperture. And what this is this kind of imaginary line from the sacral promontory region, so this very superior portion of the sacrum. And you can see it kind of skirting around the top portions of the pelvic girdle region over to the pubic symphysis to form this irregularly shaped kind of circle region. And this, as mentioned, is going to be that superior pelvic aperture. We'll talk a little bit more about it in a moment, but this pelvic brim will divide into two different regions, the greater pelvis and the lesser pelvis. So just to get our bearings, so we're in the sacral promontory region here over towards the pubic symphysis. What I'm outlining here first is that pelvic inlet or pelvic brim region. And then, of course, as you go deeper towards the pelvic girdle and you add a bit more of the connective tissue in these regions, you'll have what's referred to as the pelvic outlet. And this is a bit more complex in terms of the boundaries. It is going to be anteriorly bounded by the pelvic arch, which you can't see very well here. It would be a bit more inferiorly located, but it's in this general region here. You will continue along to the ischial tuberosities. Sometimes you hear the ischial tuberosities referred to as your sit bones. This is going to be the posterior region of the hip. You will follow along in this ligament that's going to be located between the ischial tuberosities and the sacrum, the sacrotuberous ligaments, and then the tip of the coccyx to form sometimes this more heart-shaped, smaller pelvic outlet. So the pelvic inlet is going to be a larger diameter, typically than the pelvic outlet. Now let's return to that concept of the false versus the true pelvis. So again, you want to recall what the pelvic brim is. We have this outlined here in this dashed blue line. And the false pelvis or the greater pelvis, sometimes you hear them either way, they're the same area. The area superior to the pelvic brim or the pelvic inlet is referred to as the false or the greater pelvis. It's greater because it's a little larger in this region. And it's in this region that you're going to have the inferior portions of the abdominal viscera protected. So whereas the more superior portions of the abdominal viscera may be protected by, say, the bottom portions of the thoracic cage, the most inferior portions of the abdominal viscera will be protected here. Also, you can have other structures that are located a bit into the false or greater pelvis. The uterus, depending on the size, can move into the greater pelvis. Ovaries sometimes are going to be located in portions of the false or greater pelvis. And then any region that's going to be between that pelvic inlet, so between the pelvic brim and that pelvic outlet, is referred to as the true or the lesser pelvis. And it's really here that you have the majority of your pelvic viscera, but you will have portions of the bladder here as well as the rectum. So you do have other components, but really it's separated because this particular area, this true pelvis region, is of major obstetrical or gynecological significance. All right, now let's talk about the individual bones and some of the structures that we want to know. So again, the coxal bones are sometimes referred to as the hip bones, and we often refer to the hip bones by their three general regions. So in utero and in early development, as well as after birth, the coxal bone was actually three different bones that are going to be joined together by a region of cartilage referred to as a triradiate cartilage. And so often we still talk about the hip bones in these three separate areas. So the ilium is going to be the more superior and largest component. So this is the ilium here. The ischium is going to be the more posterior component of the hip bone. And then the pubis or the pubic bone is going to be the smallest and the most anteriorly located. And you can see in differing times of development, you have quite a bit of cartilage between the bones, and then it eventually is replaced by bone. And they will all fuse together eventually in this region here, referred to as the acetabulum, which is going to be the socket component of the ball and socket joint, hip joint. All right, so let's talk a bit more about the structures associated with the ilium. Again, the ilium is the largest component. One of the most striking features, as well as a palpable feature of the ilium, is going to be this region referred to as the iliac crest. So if you put your hands on your hips, you are resting your hands on those iliac crests. So it's a very thickened superior border. So a lot of those abdominal muscles are going to have an attachment here in this region. So again, it's palpable too. Anytime you have something palpable, that can help you get organized as to where you are at in the body. The rest is pretty blade-like. It's pretty smooth. You'll have other muscles attaching in this region, but I do want to bring your attention to this region right here, which is not just a feature of the ilium. It's actually between the ilium and the ischium. So the ischium is going to be right here. And it's this fairly distinct notch in the bone. During life, there'll be ligaments that kind of close this off and basically form a foramen. And it is through this region that you're going to have the exit of the sciatic nerve from the kind of more internal region of the pelvis, external to head towards the lower limb. The sciatic nerve is the largest nerve in your body. It's going to innervate almost all of the muscles associated with the lower limb. Not all of them, but many of them. And so likely you have heard of the sciatic nerve before. You'll also have a muscle referred to as the piriformis that is going to exit through this region as well. The piriformis helps in terms of organization of some of those muscles in that region, but also importantly, it's going to be located just superior to the sciatic nerve as it exits. So if you have a hypertrophy of the piriformis muscle, it could pinch on the sciatic nerve, causing issues there. All right, the ischium, so located posterior-inferiorly. Really the dominant thing when you're looking at the ischium is this built-up region right here, referred to as the ischial tuberosity. We talked about the ischial tuberosity as one of the boundaries of the pelvic outlet. We often refer to, colloquially, to the ischial tuberosities as your sit bone. So when you are sitting down, you're sitting on your ischial tuberosities, kind of. Obviously, you have skin, you have some connective tissue there, but that's the bone that you're kind of sitting on in that region. So you have those sacrotuberous ligament attaching there, which goes from the ischial tuberosity to the sacrum. Also, one of the major reasons why it's so built up, why it's so robust in that region, is you do have your hamstring muscles and your posterior thigh having a proximal attachment here. So anytime that you have a really robust bound tubercle or a tuberosity, it often means that you have some fairly robust muscles attaching there. Another structure that is quite dominant when you're looking at the pelvic girdle is this foramen right here. It's going to be bounded by the ischial and the pubic rami. So it's not just of the ischium, but I'm going to talk about it here. And the obturator foramen has the distinction of being the largest foramen in the body. It is bigger even than the foramen magnum that we talked about when we were talking about the skull. Now, during life, this is almost completely closed by an obturator membrane. So it's closed by connective tissue, and you actually have muscles attaching on either side of that obturator membrane. So when you're looking at just the pelvic girdle with the connective tissue, you actually don't really see this obturator foramen. But when you're looking at dry bone, it's obviously quite a distinct feature. And then last but not least, we have the pubis. Often you hear this referred to as the pubic bone. This is located anterior-medially. It is the smallest component of the hip bone. And you see you have that ramus here that's forming kind of that inferior boundary of that obturator foramen. But also here you have this kind of interesting area referred to as the symphysial surface. You see the two different spellings here. I put them both here because you'll see both. And these two surfaces, so one, say the right symphysial surface of the pubic bone and the left will join to form the pubic symphysis, which is one of the joints associated with the pelvic girdle. And then last but not least, all three of those bones join in this general region, which is the acetabulum. And I put this here, this means the shallow vinegar cup. So easy to remember that, right? I always find that an interesting source in terms of the name here. And again, this is the socket component of the ball and socket joint that's forming the hip joint. All right, now we've already talked about the vertebral column, but when we talked about the vertebral column, we only talked about the movable components of the vertebral column. Now let's talk about the sacrum and the coccyx. So still components of the vertebral column, but these are the immovable portions, because what has happened is that the different vertebrae, so S1, S2, S3, etc., 4 and 5, have fused together for the most part. Sometimes you don't have complete fusion in some of these, but basically these have fused to form a synostosis, so there is not movement between the different sacral vertebrae, and the same thing in terms of the coccygeal vertebrae. All right, so generally you have 5 sacral vertebrae that have fused. Sometimes you can have some variation there. The superior portion of the sacrum is going to be weight-bearing. So weight is going to be bearing. You are going to have the formation of joints with the ilium. And you know it's weight bearing because it's a little bit wider, similar to what you had with the lumbar vertebrae. And as you get more inferior, you see that it begins to kind of taper off. And this inferior portion of the sacrum is not weight bearing, but there will be muscles attaching there. One of the most important regions of the sacrum is going to be the sacral promontory. We talked about it when we were talking about one of the boundaries of the pelvic brim. So it's this anterior projecting edge of the body of S1. It is palpable as well. and sometimes this is used in terms of certain gynecological measurements. If you're looking posteriorly or from a straight superior view of the sacrum, you will see the opening of the sacral canal. It will extend deep to this region. This is basically the continuation of the vertebral canal. But one thing you'll talk about in quite a bit more detail when you get into the neuro portion of the course is that the spinal cord actually ends around L2, around the second lumbar region. But at the end of the spinal cord, you'll have the roots that are going to form the more inferior portions of the spinal nerves that will extend within the canal, and specifically the sacral canal. And these nerve roots are referred to as the cauda equina. So more to come here, but that is what's traversing the sacral canal. Very prominent on the sacrum, you will have sacral foramina. You'll have both anterior, which you can't see in this view because we're looking at a posterior view, and posterior, which is what you're seeing here. And this will allow the exit of those ventral and dorsal primary rami of spinal nerves, specifically sacral spinal nerves, as you might guess. And then one other prominent thing here, if you're looking at a posterior view, is this region referred to as the sacral hiatus. This is created by the absence of the lamina as well as the spinous process of S5, and sometimes it will extend up to about where S4 is. This is a typical thing. Most individuals are going to have a sacral hiatus. It's not some type of formation that does not occur in most individuals. So this is going to also lead into the sacral canal. So sometimes you can enter anesthetics into this region, which will bathe those nerve roots of the cauda equina. All right, and then last but not least, we have the coccyx. So the coccyx is not a part of the true pelvic girdle. So it's really that sacrum and those hip bones, but it is going to have a attachment or an articulation with the fifth sacral vertebrae and the first coccygeal vertebrae. It's this first coccygeal vertebrae that is typically the most, is the largest, as you can see here. Sometimes you don't have a complete fusion between the first coccygeal vertebrae and the second through fourth. Generally, the second through fourth will fuse pretty distinctly. It's this first coccygeal vertebrae that you're never quite sure exactly what it's doing, but it's going to be an important attachment site. You'll have muscles attaching there. You'll also have ligaments attaching there as well. All right, so let's talk about the joints. So again, when we're talking about the sacrum and the coccyx, between the different sacral and coccygeal vertebrae, you will have sometimes it's into your 20s or past your 20s, but you will eventually have a complete bony fusion between those bones, so a synostosis. But then you do have joints that are going to persist into adulthood, and that will allow some movement to occur. And the first we're going to talk about is the sacroiliac joints. Often you'll hear these abbreviated as the SI joints. And these are very important in terms of weight bearing. So they are right here between the ilium and the sacrum. As you can imagine, you're going to have a lot of weight coming down from these regions. So this is right there at that first kind of weight bearing between those two components. And this is actually an example of a compound joint, meaning that it's kind of two separate joints wrapped up into one. And not only are they two separate joints, they're two different types of joints. You're going to have a synovial joint between the auricular surfaces of these bones. And then you're going to have a more posterior fibrous joint, specifically a syndesmosis. And the sacroiliac joint is unique for a synovial joint in that there is very little movement here. And that makes sense. You have a lot of weight bearing, you need a lot of stability, but very little movement. But some movement is needed in order to be able to deal with some of that weight. But it's generally just kind of slight gliding or kind of rotary movements occasionally. So this is a key component here. Very little movement allowed, but some movement is necessary. If you look at a straight anterior view, you will see where those two pubic bones are going to articulate. at the pubic symphysis. Now, remember, we talked about a symphysis in quite a bit of detail when we were talking about joint basics, but this is going to be an example of a cartilaginous joint. Specifically, in between, you'll have this interpubic disc that is going to be varying sizes in different individuals. So there will be some movement associated with the pubic symphysis as well, but certainly not as much as you would have in some of the more freely movable joints. Now, you can have relaxation of pelvic ligaments, which will directly affect the mobility of the surrounding joints. This is fairly typical in the latter half of pregnancy, where there's increased levels of specific hormones, so sex hormones in terms of estrogen, as well as relaxin. And this, again, this can permit as much as 10 to 15% increase in diameter, typically in the more transverse direction. So this will move the ligaments, or allow for more movement of the ligaments, which will allow for more movement of the joints. And this will help to facilitate the passage of the fetus through the pelvic canal. So, so an important area of relaxation, but also of note, these particular hormones will allow for more movement of these specific joints in the pelvis, but also in all the joints of the body. And so while that's very important in terms of relaxing in the pelvic region, that could have implications in terms of the other joints of the body. All right, excellent. We have reached our question. We did talk about some specific structures of the pelvic girdle. Specifically, I want you to remember those hamstring muscles we talked about on the posterior thighs will have a proximal attachment site to which of these structures? So take your time, look through the choices. Hopefully it pops up. If it doesn't, go back into your notes, find the answer. And then when you're ready, I hope you have landed on C, the ischial tuberosity being the correct answer. So those sit bones. The ischial tuberosity is very robust. You have ligaments attaching there, but you have these fairly strong hamstring muscles that have their proximal attachment on the ischial tuberosity. So that is the correct answer. That makes sense. Hamstrings are located posteriorly. The ischial tuberosity is posterior. Acetabulum is not correct. You actually are not going to have any muscles attaching to the acetabulum, but it's very important in terms of being the socket portion of the hip joint. The iliac crest, remember we rest our hands on the top portions of the ilium, or these iliac crest. This is a very important muscle attachment site as well, but that's more in terms of abdominal muscles, and then even some of the gluteal muscles. Obturator foramen, not the correct answer. It's going to be completely occluded or filled in with the obturator membrane, which does have muscle attachment on either side, but not specifically the hamstring muscles. And then symphyseal surface, that's going to be on the medialmost portions of the pubic bones. They're going to be important in terms of forming the pubic symphysis, but not important in terms of the attachment side of the hamstring. So this is more anteriorly placed, so that wouldn't make sense in terms of the hamstrings attaching there. All right, excellent. So that was quite a bit to go through. We had a lot of bones as well as some specific joints to discuss. Now we're going to move on to some of the muscles associated with that pelvic girdle. I'll see you in the next video. As always, please feel free to reach out with any questions.